Looks like we're in the home stretch. That's right, COVID-19 policy. It's on its last legs. I saw a few things and I was a little bit worried about it, but then finally, I see the tides have turned, the course has corrected. Let me start you with healthcare workers. Now, there was an interesting discussion recently about masking. And my colleague and co-author, Dr. Adam Sifu from the University of Chicago, who actually, you can go back a few videos and watch him give a guest lecture to my research group. He asked a provocative question on Twitter. Should everyone, patients, healthcare workers, visitors, mask in healthcare settings from now on forever? And the answers were yes and no. And when I first looked at the poll, the yeses were way ahead. It was like 75% yes and 25% no. And I thought to myself, what on earth is going on? And somebody remarked in the comments, this is an ID doctor, you left out an important option. Sometimes, how about we mask when rates of viral URIs are high in the community, maybe flu, maybe COVID, maybe RSV. Now we know it will save lives. Always and never not realistic answers. We know it will save lives. Do we now? I missed that part of the equation. The reason it's a controversial question is if I were to reflect on the pandemic, let me think about the number of cluster randomized controlled trials that tested the universal masking of everyone in the hospital. That's a good number, 0. There's 0 of those studies. So one, we don't really know for COVID-19 if this actually helped. And we certainly don't know for other URIs and influenza. We don't know what this policy means. If this person wants to come in and have some sort of scale, when it goes over we do and when under we do, you could test that. That could be the testable strategy. You could imagine multi-arm randomized control trial, cluster randomized trial, hospitals where we don't do anything, how things used to be. Hospitals where above a threshold they do it, below a threshold they don't, and hospitals where they just routinely do it. And you can imagine like a factorial design where we're doing surgical masks or N95 masks, and you can look at, all these different permutations, at least 6 there, and maybe even more permutations, and have control groups to look to see what the effect of these policies are. You could do that study. It would be the necessary study to do if one were to do this forever, because forever, it's a long time. And you'd want to do that study to generate credible evidence before you would implement this. But what baffles me is that smart people would actually say they support doing this without that evidence. I mean, that's really, really puzzling to me that an intelligent person, somebody who'd hold drugs and vaccines to the standard of evidence, is more than happy to embrace an unproven, broad-scale, sweeping policy without any evidence. And that's what troubled me about the poll. But gradually over time, people stumbled across the poll, myself among them, and then I tweeted something like, if the medicine we're practicing is scientific medicine, we would test this. And before we would just do it, and then gradually the poll has switched, and now 52% no. Well, 52% no. And I think if you actually surveyed people, I think probably most people realize that this is not how they want to keep living forever. I mean, this is a blip. It should be a blip, at least. I saw another thing that cheered me up, and this was the Cambridge University hospitals. Quote, face masks are no longer required in our hospitals, with a few exceptions. See the link below. They will still be available for those who prefer to wear one, and let the member of the staff caring for you know if you'd like them to wear a mask. But then it also goes on to say, we understand that some of our patients will have concern about this change in guidance. We do continue to offer the option of virtual appointments. Please contact the clinic to discuss with our teams. It's basically saying, we're done with this, and, if you really are upset, you're going to have to take your services virtually. And I think that that's a bold stance that Cambridge University hospitals, this is the NHS, this is Cambridge University in the United Kingdom, a venerable university. I think it's a bold stance they're taking, but a necessary one, because sometimes people need a little encouragement to give up a comforting thing that has no credible evidence, but a comforting thing. They need a little bit of a push, and that's what they're doing. And I suspect that we all know what's going to happen. There's no surprise what's going to happen. What's going to happen is calamity. No, just kidding. Of course, nothing's going to happen. It's probably going to go silky smooth, like pulling back all the other restrictions over time. Just going to happen. Pull back. Most of the patients and staff have probably had COVID-19 already in the UK. Most have been vaccinated. It's just going to be an uneventful thing. And then another hospital will do it in another hospital. And then like dominoes, they'll all fall and we're going to give up this foolishness. Because we're not going to be masking, I really don't think, in perpetuity. I think that would be a ridiculous thing. That would basically be saying that without any evidence that it works, by evidence I mean good evidence. When I talk about evidence, I usually mean good evidence. I don't mean the kind of evidence like we compared hospitals that did something to what. No, that's not good evidence, people. When you talk about something that has a strong political and cultural ideology, the places that jump on doing it and the places that don't aren't really comparable in other ways than the thing they jump on. And that's just a fundamental limitation of all these terrible retrospective mask studies. That's why you need to do randomized trials. That's why it's the gold standard in medicine. And I used to think that people knew that, but I don't think so anymore. Actually, I was going to make a joke that one of the biggest reasons drug companies generate such tremendous revenue from such marginal products is that doctors aren't good at reading medical literature. And COVID-19 teaches us that they're going to be making money for years to come. They're going to make a lot of money because they're not really good at it. They're not good at it. They're not trained at it. They're not comfortable at it. They really are just kind of responding viscerally. Later on in that thread, I think, Dr. Adam Sifu commented that, he chooses not to wear a mask when he's not required on airplanes and in restaurants. And the moment he's no longer required at work, he's not going to do it. And then people screenshotted that. They said, what a terrible person who would not want to. It's a bit odd. It's a bit odd behavior because I think probably the majority of people will totally agree with him. And proof of that is if you just walk around and look around an airport, you would see the majority of people do agree with him. And I think that's certainly true in the hospital, and the moment that they rescind these rules, mask usage will plummet in all but the most extreme liberal locations because, of course, it has a lot to do with political valence and not much to do with evidence or COVID numbers or anything like that. The next thing I was thinking about, Ashish Jha had a tweet, and this tweet said something like, guess what? A new randomized control trial of Ivermectin shows it doesn't work. No need to use the horse dewormer. We've got drugs that do work, like Paxlovid. Yeah, they love Paxlovid. I got a few things wrong with this. Number one, if you're the public health czar for the United States, you've got to be very careful about demonizing ivermectin as horse dewormer. Ivermectin, of course, has a lot of human uses. It's a real drug that has done a lot of good, and the people who take it shouldn't be marginalized or pushed away with that kind of pejorative language. That's not helpful. That's not what a public health official should be saying. So it's a simple error, but it's got another error to it. My views on this topic are very clear. You can go back and watch. I think I made a video with Zubin Damani a long time ago about ivermectin, hydroxychloroquine, vitamin D, as well as Paxlovid and remdesivir and whatever you want. My point of view is simple. My point of view is that when you look across all drug development, the pretest probability any single drug will help, or even a combination, is very low. It's a lot lower than people think. And then you think about what's the kind of evidence you need to move from a pretest probability that this probably doesn't help to a post-test probability that it actually does help. And the answer is a well-done randomized control trial. It doesn't have to be cluster, because here we're talking about individual benefits to people taking a product. So it doesn't have to be cluster. It's not about transmission. Unless it is about transmission, then in which case it might have to be cluster. But if you're talking about benefit to the person taking it, it doesn't have to be. It's an individual randomized control trial. You want large, well-done randomized control trials free of bias. You don't want to pool together retrospective observational studies. A big pile of trash is called a landfill. It's not called a meta-analysis. That proves your point. I know some of you like to think so. That's just garbage. You can pool together garbage studies that show cloth masking toddlers helps, and you can pool together garbage study that shows taking vitamin D helps in an observational cohort. That's not sufficient. And don't talk to me about vitamin D levels or whatever you want. If you believe that taking a pill helps, do a large randomized control trial showing that people who take that pill do better than people who don't. It's a very simple bar. It's the same. If you believe a non-pharmacologic intervention works, do a large randomized control trial showing it works. I have the same standard for anything, okay? It's the same standard. It's the evidence-based standard. It's the only sensible standard. Pretest probability anything works is really poor. Until you have credible evidence, you should not believe anything works. Anyway, having said all that, I was open-minded to the results of the ivermectin randomized control trials. Every large, well-done study to date, including the new one that just came out, is rather sobering. So I think we're going to have to say it probably doesn't do much, which was where the pretest probability was, because nothing probably does that much. But Paxlovid, what really interests me here is that Ashish Jha is happy to demonize He's happy to demonize ivermectin and those horse dewormer people while recommending Paxlovid for vaccinated Americans. Because, by the way, the majority of the use of Paxlovid is in vaccinated Americans. It's vaccinated people taking it. And it used to be high-risk people, but as we all know, anyone who sees how it's being given to all sorts of people. I know many young, healthy people who've taken it for COVID-19. And I know people who've been vaccinated once, twice, 3 times, and 4 times who still take Paxlovid. It has 0 randomized control trial evidence that's published and available in vaccinated people. 0 randomized control trial evidence in young, healthy populations that are vaccinated. 0 randomized control trial evidence. So they want to get on their high horse and say, don't take that medicine that, doesn't have good evidence. Take this medicine that has no credible evidence in vaccinated people. That's crazy to me. The answer isn't that it works or it doesn't in vaccinated people. I don't know the answer. We'll get the answer. The UK is running, I think, the panoramic randomized control trial. It's going to give you the answer. Let me point out one thing. If the UK's randomized control trial of ivermectin, or of Paxlovid, get these two, Paxlovid, if that randomized control trial is negative, do you know how bad it's going to be? It's going to be real bad. We're going to have just spent $5 billion plus on a product that didn't help. If that's negative, I think there's going to be huge repercussions going forward for this administration, for future, how we should even allocate drug products in the times of crisis. It's going to be explosive if that's negative. I hope, as I always hope, that randomized trials are positive, that we have real advances, but I worry that they might be negative. And I worry that simply because, most drugs, as you drop down in absolute risk, have smaller and smaller absolute risk reductions. And often the relative risk reduction is not even preserved. And there's already a hint of that because even in the Paxlovid high-risk unvaccinated randomized control trial, some people on entry had pre-existing antibodies to SARS-CoV-2, and those people have a much, much smaller reduction in bad outcomes. And we'll see what happens to this group. I think this group might not go so well. So what do I think is ironic here? I totally understand why somebody who comes across very condescending about evidence, who they themselves recommend things based on low evidence, is a hypocrite. I think that's very hypocritical. The Biden administration and the U.S. Food and Drug Administration, they had an opportunity not to be hypocrites. They could have told Pfizer, if you want $5 billion and methinks you want that, you're going to have to publish the randomized control trial first. You're going to have to run a randomized trial. But this is when one gets into politics. One must worry that sometimes an administration wants something it can give people and not necessarily something that works. And that's a worry that you had early in the pandemic when one administration said hydroxychloroquine, bleach, and light. And that's a worry you might have even now in the pandemic when one administration facing midterm losses that are going to make your head spin wants to have Paxlovid, so we're giving people something. We're not just letting the virus run unchecked. We are treating with therapeutics. They want that. And so I don't think that the administration has an incentive to generate credible evidence. And so you see 2 political administrations more than happy to jump on things that don't have what sensible doctors and evidence-based medicine people want: randomized control trials in populations that resemble the population you're giving it to that show benefit. For Paxlovid, they have a randomized control trial, but the population is unvaccinated people who mostly didn't have COVID, who are at high risk of hospitalization. That's not the group we're giving it to. We're giving it to people who are mostly vaccinated, who are at much lower risk of hospitalization, and some of whom may have already had COVID. So these are multiple ways in which they're dissimilar. That's not good. And I think, the last thing, Canada. I see Justin Trudeau has had COVID-19. A second time, Justin Trudeau, second time. 3 vaccines, 2 COVIDs. He's got 5 times is the charm. What's the problem? He said, I'm mostly feeling fine. The politician always like, it would have been worse if I weren't vaccinated. Yeah, of course, it's very difficult to make such a claim like that because one doesn't really know the counterfactual for an individual. Anyway, I'll let you have that. You want to say that, that's fine. But the real crux here is, why are you testing positive? They always say testing positive, not he was sick and went to the hospital and got tested. There's a simple solution to all the woes here. It's called don't test healthy people who aren't being hospitalized. That's what other countries are doing. That is the Denmark strategy, that if you're not going to act upon that information, if you're only feeling mildly unwell, if you're not at high risk of hospitalization, you don't need to test. That's what the Danish health authority is telling people. It's a very sensible strategy. It will be the only long-term strategy. Don't you see that? Because in the long term, 1 year from now, 2 years from now, you think people will be obsessively testing for COVID-19 and at any sign of it, calling in sick for 10 plus days, etc. It's just too disruptive. It's not going to be able to be sustained. I don't think it's going to be sustained. I think Justin Trudeau had a simple answer, which is, I worry that Justin Trudeau and other elites are being swabbed all the time for COVID. They don't need to be. If Justin Trudeau isn't at high risk of being hospitalized, and I doubt he is, given the fact he's had 3 vaccines and a COVID, I think he should probably never be tested, ever. And that's much more sense. Except if he happens to go into the hospital feeling very sick with a respiratory infection, then by all means test him. But short of that, I probably wouldn't test him. What are the lessons here? I think the tide is turning. Is it not turning? Huh? The Cambridge University Hospital is dropping masks. It's a big move. And nothing bad is probably going to happen. Nothing bad is going to happen, and then it's going to spread. It's going to spread, and other hospitals are going to drop it. And Adam Sifu posted a provocative poll that initially was going one way. Somebody said that, well, depending on the level of URIs in the community, then we'll always mask or not. It's not all or nothing. Depends on the level. Let me see where they found the evidence to support that strategy. Oh, it's right here in the trash can, because there's no evidence that support. Just people just making things up. Is making things up how you set policy at a hospital? No, you set hospital policy when you run randomized controlled trials. We used to do them. We still can do them. It's not too late. It's really interesting to me that zero cluster randomized control trials were run in the entire U.S. pandemic. We're talking tens of trillions of dollars just lost, and nobody ran even one cluster randomized trial in the United States. How is 0 the right number? How can anyone defend that proposition? It just speaks to a culture that is either in decline or ignorant or unable to produce science. I mean, I think the CDC, I would just start firing people who are complicit in this. I mean, how can you be an organization that sets policy in a pandemic and runs 0 cluster randomized trials? You have no clue. They have no clue about any of their policy. They never have, never will. They're just going to do these terrible retrospective studies and publish them in that MMWR, which is really just sort of a comical journal at this point because it's just such low quality. And I really, really struggle to think how they believe they did a good job. I suspect that, the truth is, somebody's asking me today, well, when do you think people will really feel differently? And I really think that the analogy for how this will move through the culture is actually very much that Iraq war analogy. I remember where I was on 9/11. I was a college student. I remember seeing the plane. I remember how I felt devastated. And I remember how my colleagues felt. And I had a lot of colleagues that were colleague students. I had a lot of fellow friends who were students, strongly left of center, strongly anti-war. But I think even the most anti-war amongst us were often very quiet as we moved into Iraq and Afghanistan. I think a lot of people were quiet back then. They didn't know enough. They didn't comment. They certainly didn't oppose it in the beginning. But then just a few years in, it became abundantly clear that we were misled. We went there under false pretenses. It was a quagmire, and it may not have made us safer, may have made us more vulnerable. And then eventually public sentiment shifted so dramatically that by 2008, it was almost political kryptonite to even have ever been adjacent to supporting that decision. It was so bad by 2008. So we moved to that, just in a few short years. We moved there 7 years. We moved from, one extreme to the other. And I think COVID-19 will have the exact same thing on schools, on the New York Times coverage of schools, which was just atrocious. And really, if you really had a COVID-19 investigation, the New York Times and what they were doing and why they chose to consistently highlight the fear-mongering stories around kids that almost single-handedly kept kids in blue school districts out of school for an extra year, I think that'll need to be investigated. I think people will feel worse and worse about their coverage and what their coverage meant. I think all these perpetual restrictions, the on and off restrictions, people will feel worse about. The mandatory vaccine mandate, people lost their jobs about that. I think people are going to regret that choice. The boosting mandates, people will regret that. The moment you learn vaccines don't stop transmission and you continue to have vaccine passports without the one ethical prerequisite to even think about it, I think it's a bad idea. Even if you had that ethical prerequisite, I think it pragmatically didn't make a lot of sense, but without that, it's certainly unjustified. And I think the colleges and all their extreme precautions and this idea that we will mask in perpetuity for another 100 years, the constant villainization of anyone who suggested trade-offs or anything sensible, I think all of that is just going to keep flipping. And 7 years from now, it's just going to be, that anyone who strongly held those views is going to be thought of very poorly, just as people who strongly endorsed the war in Iraq will be thought of very poorly. And the only overall sentiment will be lockdowns, grievous error, school closure, the worst error, perpetual COVID policy mandates, a big error. Pretty much vaccination was all you could do to lower risk. Then thereafter, you should have just returned to normal life. Either you wouldn't be able to spread the virus, in which case you don't need to mask, or the vaccine is ineffective at halting transmission, which is what it turned out to be, in which case there's no point for continuing to mask, even if it worked, because we don't have data that it works. But even if it did work, there'd be no point because breakthrough would be inevitable. So you're kind of in that kind of logical puzzle box. And I think more and more people will come to that as the only sensible conclusion. So those are my thoughts. This is the COVID roundup. A lot of drama out there. Great poll. I like to see that vote switch. I like to see it switch. I like to see, more than that, I'd like to see evidence. Justin Trudeau, I wouldn't have tested him. Take Paxlovid, not Ivermectin. I would recommend that we do randomized control trials in vaccinated people before we spend $5 billion. I'm a simple person like that, and I think the pretest probability for all these things is much lower than people think. That's my experience, and that's what evidence would suggest when you study drug development. So this is what you get on this channel. You get this, and you also get those clickbait videos that are about cancer drug trials. I've been told that they're clickbait. It's interesting it's a strange type of clickbait that nobody seems to want to click on. But I heard it's clickbait. Clickbait video. You get those videos too. I've got some slide decks from ASCO that I want to go through in a future video. I'm going to be back to talk about that. You know what to do if you like this. Like, subscribe, comment, leave a message below. Check out our podcast, VPZD. Check out Plenary Session. That's my oncology podcast. Check out Substack. I've got a lot of good stuff coming on Substack. You should subscribe. Check out Twitter, I guess. You don't have to check out Twitter. It's a waste of your time. Check out those other places. Until next time.